A 72-year-old woman arrives in the emergency department. She is severely short of breath, unable to lie flat to sleep, and her legs are heavily swollen. At its core, heart failure is a mechanical plumbing problem. The central pump can no longer meet demands, causing fluid to back up into the lungs and lower extremities. As the heart stretches to handle this overload, it releases a specific biomarker, NT-proBNP. Confirming the pump is failing is only the start. To actually fix the system, we have to look inside the heart to see exactly how the mechanics are breaking down. This requires an echocardiogram to measure the ejection fraction, which splits patients into two distinct treatment pathways. Left, heart failure with reduced ejection fraction. The dilated pump is weak. With EF under 40%, it cannot squeeze effectively, requiring a 4-drug protocol. Right, preserved ejection fraction, EF over 50.
The heart squeezes fine, but stiff walls prevent filling, requiring SGLT2 inhibitors. Knowing whether the heart is too weak to squeeze or too stiff to fill dictates which medications are safe to initiate and which will provide no benefit. Before initiating chronic medications, the patient must be stabilized at the bedside. This hemodynamic grid organizes clinical status. The x-axis measures perfusion, warm or cold. The y-axis measures congestion, wet or dry. Most present warm and wet, adequate flow but congested lungs. Intravenous diuretics and vasodilators clear this edema and reduce fluid load. Acute stabilization stops the immediate danger of drowning in fluid, buying the time needed to implement long-term, survival-based therapy. Once the patient is dry and stable, you begin guideline-directed medical therapy. For a weak heart, we use the Fantastic Four to reduce mortality: ARNIs, beta blockers, MRAs, and SGLT2 inhibitors. Let real-world comorbidities create friction points. A systolic blood pressure below 90 locks out ARNIs. Potassium at 5.7 prevents starting an MRA. Consider a patient with heart failure and type 1 diabetes. Which of the 4 core medications is strictly avoided? SGLT2 inhibitors are withheld here. In a type 1 diabetic, these drugs carry a high risk of triggering diabetic ketoacidosis. Success in these cases relies on reconciling guideline targets with the specific physiological contraindications of the patient. This creates a critical distinction in clinical exams: drugs that improve survival versus those that only improve symptoms. If a patient remains symptomatic on the foundational 4 drugs, adding digoxin is a frequent temptation. On this scale, the Fantastic Four carry the entire mortality benefit. Digoxin and loop diuretics only provide symptom relief. They make the patient feel better, but they do not help them live longer. Clinical decisions should always prioritize maximizing the mortality-reducing therapies first. We can now view the entire patient journey through a single decision engine. The pathway flows from symptoms to the NT-proBNP biomarker, through the echo to identify the phenotype, into the acute grid for stabilization, and finally to chronic medication checking for exclusions. Take a screenshot of this complete algorithm to use as a clinical cheat sheet. This structured sequence transforms heart failure management into a series of logical, mechanical adjustments.